Canada, working at an ECMO center. I think we do between 80 to 100 ECMO a year, mixed between BD and
welcome everybody to the conference and to the workshop in particular. My name is Ali Al-Hazmi. I'm in Toronto, and I'm currently working in Saudi Arabia. I have been moving through Riyadh, and currently I'm the national leader for ECMO services in Saudi Arabia Ministry of Health. So I'm supervising, as of today, 16 or 18 centers. If we start with some of them are cardiac, most of them are complete centers. I've been working in three specialist hospitals after I came from Canada for around 8 years before I moved out. So it would be nice to hear from you and discuss in an interactive way.
Hi everyone, my name is Patrick Yobushevsky. I'm a pharmacist. I practice in cardiovascular surgery and ECMO at Mayo Clinic in Minnesota, US. At our center, we do approximately 150 to 200 adult runs, around 30 pediatric neonatal per year. And I serve as the chairman for clinical pharmacy research at Harvard as well.
So just before we start, just to get a sense of who is our audience, can I get a sense of who is working in the center where you currently have ECMO patients? And how many cases a year approximately? Monthly or yearly? Just a rough idea, is it like 5 to 10, 25, 50? More than 10.
10 to 23.
Probably say 20, 25 thereabouts.
And the others, you've never seen ECMO before? You've seen a machine before? Well, you have two over there. Here you go, this is yours.
During COVID, it was we working in the Jam Hospital.
Yep.
There is special ICU for central ICU, all for big cases. Down there around 20 cases, but after that we should move to other hospitals. So the number reduced.
Sounds good. And also, who is a nurse in the room? Yeah. Physicians? Anything else? So we'll try to make it as interactive as possible. Some of you have seen some of your patients, some of you have never seen some. So please, it's a small group. Ask questions. We have an agenda, but we're very happy to go and answer your questions so that it's as useful to you as possible. So I let Adil start.
So we'll start. I think just because some of you guys are new to ECMO, so we thought of the first session to be interactive and built on to your level, to where you are, so we can start from there. And the first lecture is about one slide, which is good, which is this. And however, we have some hands-on for the machines for you guys to see, since more than half have never seen ECMO before. Okay, so basically ECMO is an extracorporeal membrane oxygenation, but this is, in short, we're trying to describe extracorporeal life support. But since, especially here in the Gulf, we're used to ECMO as the main or sole ECLS technology we use, so we'll concentrate on that. So probably you have seen, I think in Jabir you guys use Genius, right? You're using. Who uses this? Who have seen or touched the machine before? Okay, so very, very quickly, so you guys can interact and understand as we go through the cases, because this is case-based discussion for the cases. We will talk mainly about the main extracorporeal life support or ECMO circuit configuration, rather than using the hybrid. Probably we'll touch on it, but eventually let's focus on these two. So this is VV ECMO and VA ECMO. You guys know what is the difference? Okay, so just so we are all in one page, extracorporeal membrane oxygenation is probably best described as a circuit in addition to the native circuit. So the native circulation is cardiopulmonary circulation. Blue blood going to the right heart, pumped to the lung, becomes red blood, and then distributed to the body for oxygen extraction. Correct? So this is the normal circuit, the normal circulation of normal physiology. ECMO is not normal at all. It's actually you're challenging the normal by putting another circuit, trying to harmonize these two circuits together. Okay? So in VV ECMO, which is a venous access, draining blue blood, let's agree on blue and red for now. So draining blue blood, sucked by a pump, through the oxygenator becomes red, okay? And that goes back to the right heart. The right heart that is used to receiving what color? Blue. But now it's receiving red. So oxygenated blood. So this blood goes to the lung. Say hi for the lazy lung that's not doing their job. Then going back to the left heart to be distributed. So this is veno-venous because you're draining the vein going back to the vein. Okay? There's a huge paper about nomenclature, the drainage, the access, and so forth. But this is just to bring us all at one page since we have different levels of expertise and knowledge of ECMO in our group. The second one, which is veno-arterial. So again, you're putting a camera, which is used to suck blood out of the vein, which is what color? Blue. Goes to the oxygenator, which is the external lung, transferring this blue to red, right? Then you go back, but you don't go back to the vein as here, you go back to the artery, okay? And since mostly we go through femoral artery, let's say 90% of the time or 85% of the time, unless you're a post-cardiotomy patient, that means your blood will be pushed upward, right? And we said that the normal physiology, the left heart will be pushing blood down. The right heart will push to the lung. Blood goes from the lung to the left heart will push down. While here, we're going exactly the opposite. What is the largest street you guys have here? Your largest street. So have you been to Dubai? You guys have been to Dubai. Sheikh Zayed Street, which is basically 8 lanes, I think, going that way. Okay? From two directions, right? So one is going, one is coming. So imagine within this 8 lanes, all going from, let's say, north to the south, there are 10 cars going opposite within that streamline. So you can guess how the turbulence and right? This is very important because that would probably some of his lanes and mine would be touching based on that. So you have to put that in mind, that this circuit has to interact with the internal physiological circuit in different ways, either in the veno-venous respiratory support that gives oxygenated blood to the body when the lungs do not work, or when you give an arterial blood push when the heart is too weak to generate enough cardiac output to maintain the blood pressure. So replacing the lung or heart and lung, despite you're making a big sound. Okay, so this is very important. The interaction here is important. The interaction here is more important and interesting. So always think of your patient when you approach the patient in the case studies we will present. Always think of the patient who is connected to a monitor, to a ventilator, to a CRRT, right? But also think of this other circuit running, which is the, okay? So if we are looking here at the Xenius very quickly, this is the insertion This is the circuit that you are given to the surgeon, or in my country, the cannulation is around 80% based on intensivist. They will give me this, I will open it, and I have to be, no matter how late this case is, I have to be very vigilant that the blue will be connected to the drainage side, right? Because this will go to the pump, this tiny pump, which will suck the blood, then direct it to the oxygenator. Blood will come out from the oxygenator in red color. That's why the colors are very important. And this will go back to the patient in an arterial axis, if this is VO arterial for cardiac support, or in the venous axis, if this is VV for respiratory and gas exchange support. Okay? So this is one circuit. For example, if the flow is compromised because of your axis, you will see very clearly here the flow is changing. Okay? And this blood that's flowing through the oxygenator has to be, where do we connect this? Especially for nurses, where this goes? To the oxygen source to the wall, right? So this is the blender that I can change how much if I tour the oxygen that will be displayed here, and how fast that oxygen flow is, or gas flow is, which is the sweep gas flow, which will play with my CO2, while the Fi2 will play with the oxygenation. So just very quickly, in case any of my colleagues wants to use the machine for explanation, what is this? So this is the flow. So you have 2 liter flow per minute, and this is the RPM, which is round per minute. So if we unlock, okay, so it is locked. So we have to unlock. Okay, so if we go up with the RPM, say to, which is how fast it's running. So let's go to 5,000. Your flow has what? Increased. Okay, and you can hear very well. It's flowing more as I increase the RPM, right? So this, the suction generated by the pump. Have you seen that before? No, this is not open. Okay, so this is the Mackay. So just to familiarize you, so because it would feel much better if you go out of the workshop knowing what we're talking about. So this is the Mackay, okay? So when I was in Toronto, we haven't been using these yet. What are you using now?
Mostly those.
Mostly those again. So these came around 2014 to the market of 2012. In our area in the Middle East was the MERS-CoV era at the time. So CardioHelp again is very easy, the interaction is very easy. And then again, you can play with the pump and you play with the RPM to generate the figures, okay? Because you can change the RPM as much as possible, and then you know that for this patient, RPM of 5,000 will generate 3.9, but then any external changes can play and adjust onto this, okay? So in the Mackay, the nice thing about it that I like is that the emergency drive, okay? So, because if you, especially if you are in a VA technology or configuration, if you, for a reason, let's say this pump stopped for a reason, or the battery stopped, or disconnected, although this battery should stay for 6 hours, okay? So let's say for whatever reason, the pump failed. If you are especially on a VA ECMO configuration, what will happen to the patient? The blood pressure depends on your flow. So what will happen? Yeah. Arrest, most likely. If not hypotensive, then arrest. So the first thing, if this doesn't work, you have to move to the emergency drive. And that's what we train our bedside nurses, because by the time the perfusion will come, the nurse and the bedside physician have already taken over that. So this is electronic, while this is easy for all people, which is us. You can put the circuit here, the delivery circuit, and then you can hand crank it. So if you hand crank it, you can see here. Yes, here. You you can see how fast is your RPM. Going to approximate what you were using, 3,000, 5,000, whatever. If we would have a second, I will show you that it's a big pump, while this one is a tiny pump. So for this one, you will use higher numbers than, you will go to 3,000, 2,500 RPM here, equivalent to around 6,000 here. So this is much smaller, which might come to your anticoagulation, but this generates much less thrombocytopenia and platelet disruption because it's very small. Okay, any question? At least we have a common ground on where we're starting. Any question? So very
Why does
quickly-
the small one generate less hemolysis?
This one?
You said that the small one generates less thrombocytopenia.
Yes.
Right? Why is that?
So some people think because of the surface area interaction with the plastic. Because you're having, and the speed.
So there's lesser surface.
Yes. Yes. So because platelets don't like foreign surfaces, right? That's one of the issues. Okay. So very quickly, VV, venous, pump, oxygenator, venous, for respiratory support, gas exchange, oxygen and CO2, okay? Giving the right heart, which is used to getting blue blood, red blood, goes to the lung, left heart, then to the body, right? And we use it when the lung doesn't work. Very easily here, veno arterial, is right from the vein to the pump, oxygenator, red blood comes back into the artery. And in a peripheral veno-arterial echo, mostly we bring through the femoral, which as we said, this is 10 cars going against the normal flow of 10-lane street. Okay? So imagine the chaos created by that, which is very important. Okay? Because of this change of direction, as we said. So imagine if I am a factory, I'm running a factory, and then my mother-in-law tries to come and help me by running another line of this factory, but in my house or wherever I am. So imagine both of us interacting. This is always put that in mind. Having an ECMO patient is actually two circuits. The patient circuit and the ECMO circuit and how much it interacts. If you have an open chest, you will go centrally, so through central, and then if you put this arterial cannula here, then you will flow with the aorta, right? So your cars will flow with the normal flow, okay? Any question?
Yeah, we guide it to femoral, but we will reach up to our.
No, I'm saying that if you have a cannula that goes from the femoral there, the blood injected from the cannula goes this way. While the aorta pushes blood this way. So what is cardiac output? Stroke volume times heart rate, right? So my stroke volume is 100 ml for ease of calculation, which is never this number, let's say. And then my heartbeat at 60 times a minute, this is 6 liters. My heart will pump 6 liters. So my heart now is sick, that's why I need ECMO. So we cut this by half, say the heart will pump 2 liters, for example, okay? And my ECMO flow is how much now? 3.9. So I'm pushing 3.9 this way, and the heart is pushing 2 liters that way. So you will have, but these cars must move, they cannot crash, okay? So what you will find a lot of beep, 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 a lot of turbulence, and the area where they meet is what we call a mixing cloud, which I think his name always comes to, I'm burning her tongue. Okay?
To answer your question, yes, the blood is reflected in the aorta.
Yes, it is going in the water.
But it will go far or not far depending on how much the heart is still infected.
Yes.
But you're right, it's from the femoral inside.
Okay. So imagine we are pushing 3.9 liters here. You think it will go up here, right? But if, let's say, for a reason, we drop the flow into 1.5 liter, probably we will not reach as high or even to the heart. Probably we'll stop until here. And the whole heart will be pushing that much. One last thing I want to say is, so the ECMO function is to flow, right? You must flow all the time. If you stop flowing, this is dead. It coagulates immediately, not very immediately, but immediately it coagulates, stop working, then whatever function you want is eliminated. Okay? So it should keep flowing. So for example, let's say we went to CT scan, we came back, we put this so much, so the nurse pushes it too much to the bed, and eventually, these are very long, okay? So let's say this is squashed between the bed and the patient and the machine. What happens is the flow drops, okay? So the flow needs drainage. That's very important, okay? Okay, so you drain. Okay, good morning. I slept so well. Okay, so then you need that suction effect. So you need an open drainage access. So we need an open drainage access to drain, okay? And then you need a functioning pump, not a pump that doesn't work, right? And then you need a free of coagulation. So let's say this is clot, so full of blood, okay? Then you cannot flow. And then you go back, again, your access has to be open, and then you are faced with the resistance from the, wherever you're going back. Are you going back to the vein? Usually the central venous pressure is not high of a resistance. Or you're going back to the artery. Okay? And the nice thing about this is that you can see the P1, P2, P3. So P3 is the pressure in the arm going back to the patient. So if the pressure here is 120 and the patient's pressure generated by the poor heart is only 40, you can push the blood. But if this pressure is 100 and the patient's blood pressure is 200, then there will be the afterload, which is now was talking about. So this flow depends on the pre-pump and oxygenator and after. This is in physiological way, but actually there was a lot of calculations and advanced things, but I'm giving you just hints too. We can start on, I think this is the common ground we can start. Any questions? Clear? I think you want to say something? Or you want to start? Okay, is there anything? Did you understand what I'm saying?
We understood the mother-in-law. She's very cute. Yeah.
So we'll go into some of these concepts to understand the basics and what are some of the issues that can happen when providing support. So we'll keep things simple. Again, we're not talking about the hybrid configuration. We'll stay with simple VA, VV, ECMO. Most of the time, this is acceptable for longer duration of support. The materials, they tend to be biocompatible. Small prime volumes, you can see here, this is prime circuit. This would, if it was sterile, it would be otherwise ready to go for cannulation. Probably only about, if you don't include what's in the bladder, maybe 600 cc of crystalloid. Relatively small surface area. You can see this is very portable equipment. It's not cardiopulmonary bypass. It doesn't take up half of this room. And these devices, the membranes, are extremely efficient in providing satisfactory gas exchange. So keeping ECMO safe is the use of integrated circuits. The bladder here is for demonstration purposes, but I think most centers won't use bladders for contemporary ECMO support. Difference between cardiopulmonary bypass. Fewer access points, the less places you can add connections, the better. Again, keeping things simple is safer, and minimal connectors. Sometimes connectors are not avoidable. You need to have a Y site or something, but in general, the less is better, simply and safely. So we briefly talked about the pressures. There are some pressures that are the most basic ones that are important to understand during ECMO. First is the pre-pump pressure. This is the inlet line pressure. So when we talk about ECMO, we talk about inlet, outlet. Inlet goes into the circuit. Outlet is what comes out of the circuit. So the circuit is always the reference when we talk about these things. So the inlet line pressure is essentially the venous drainage pressure, the pressure that is produced by the pump. So the pump is a centrifugal pump. It produces a very high negative pressure, similar to a garden hose. You unscrew the garden hose and it's a negative pressure that pumps the water through. That's the inlet line pressure. Sometimes it's called the venous pressure. Then we also have the pre-membrane pressure. So this is also venous pressure, but it's before the membrane lung. And then we have the outlet pressure, which is the pressure in the outlet line after it exits the membrane. This is sometimes called the arterial pressure. Even if you're on VV ECMO, it's still called the arterial because it's red blood either way. But more correct would probably be outlet pressure. And then we have the transmembrane pressure, which is the pressure differential before to after the membrane. This is sometimes called the delta pressure, the delta P, or the pressure drop. People will call this something different, but delta P is usually the most common reference to this. So these are the basic pressures that we'll talk a little bit more about when things can come. Some issues come up during ECMO support, but at a minimum, these are the ones that you should be aware of. I'm not familiar with this system, but the CardioHealth, almost, I would say all systems have these basic pressures on them. So this is fluid dynamics law is something that I think is critical to understand. If you understand this basic concept, you can fully understand how ECMO works, what issues come up and how to troubleshoot those issues. Very simple relationship between flow and other variables. So flow is directly proportional to pressure. It's also directly proportional to the radius of the medium of which fluid is transiting through, so the radius of the tubing. So in ECMO, you can see the size of the tubing here. We don't have cannulas, I don't think, but the size of the cannula will be relational to the flow. And then inverse would be the length of the tubing, so longer tubing. If you have too much excess, that inhibits how much you're able to flow at a constant pressure. And also the fluid viscosity, which usually in clinical practice isn't that consequential, but there are some situations where it can be. I think this specifics is beyond the workshop, but in general, when deciding on sizes of cannulas, we need to understand the relationship between the flow and the pressure drop. And so you can see, as you would expect from the fluid dynamics relationship, as your flow rate increases, your pressure drop increases. And then again, here it just shows the difference between how you change the radius of where blood is passing through. So the inlet line pressure, again, is the venous pressure that is generated by the negative pressure of the pump. This pressure is generally always negative. If it's positive, you have a real big issue. The Extracorporeal Life Support Organization says that this should not exceed -300 millimeters of mercury. In general, in normal sized adults, not exceeding negative 100 is typical. And again, these are pressures that will be displayed on the console. And they can also have, I believe most systems can have safety settings, so you can set for alerts if the pressure exceeds a certain margin of what you've set the acceptable pressure to be. But in general, somewhere between negative 50 and negative 100 is typically normal for adults. Problems if the inlet line pressure becomes too negative. You have hemolysis, you have something called chatter, where the lines start to shake. You can have a suck down, and in severe cases you can have air cavitation, so generation of air bubbles because of excessively negative line pressure. The reasons this happens is usually because you're trying to crank the pump too much, right? So we saw earlier as you crank the RPM up, you generate more negative pressure, which generates more flow. But these are situations that can create issues with providing support. So the reasons why you might have too much inlet pressure, again, if you look at the relationship will tell you all the reasons. You either have too much blood flow, you're trying to pump too much, and so the inlet pressure is too negative. You could have a kink in the cannula. Someone might be stepping on it, there might be a clot, something that impedes flow. You could have low filling pressures. Usually this is the most common reason in practice. You have a patient that is dry, low circulatory volume that is not compatible with how much you're trying to flow. Or you could have external pressure around the vessel. So we drain from a great vein. So if you have high intrathoracic pressure, high abdominal pressure that compresses the vena cava, this can generate increasingly negative venous pressures. So excessive coughing or high thoracic pressures can produce very low inlet pressures. The outlet pressure, again, is the pressure off the membrane, so the arterial pressure. This is positive. If it's not positive, you have issues. This is the pressure that's generated by the pump. It also says that this should not exceed 400. In general, not exceeding 300 in adults is typical. The consequences of too much outlet pressure are hemolysis. Again, you're trying to pump too much. You could have disruption in the operation of the circuit, have blood jetting, or a situation that is almost always catastrophic is the fireman hose. This is a phenomenon if you have a hose and you're pumping too much through it and the pressure is too high, the hose starts to come out. And so the same can happen with a cannula. If you're pumping too much through, you have too high positive pressure, that cannula can come out of your femoral artery and that can be catastrophic. So if we look at the relationship, we can understand what the reasons are for too high outlet pressure. Too much blood flow is one of the most obvious. If you have a kink or clot in the arterial side or the outlet side of your circuit, this can cause high pressures. If your patient is hypertensive, if you have a high systemic afterload, like was talked about before, the relationship between the ECMO and the native aortic blood flow, if you have very high aortic afterload, this can increase your outlet pressure. Or if you have a occlusion within the membrane itself, or if the membrane is highly pressurized. Then the last pressure is the transmembrane pressure, or the delta P, the pressure drop.
This again is the pressure differential before and after the membrane lung. So it's the resistance that's generated across the membrane. This is a calculated value in many systems rather than a measured value. The trend of this number is more important than the absolute number itself. In general, 10 to 40 is typical for adults. Higher is worse, right? Because you're increasing the resistance across it, which is not good. If you have too high resistance, you can have hemolysis, disruption in the operation of the circuit, membrane failure, or embolism. And again, trending the delta pressure is much more important, but understanding that the membrane pressure is an inputted value that depends on the flow. And so if you're flowing at 2 liters and you have a certain membrane pressure, and now you're flowing at 4 liters and your membrane pressure is higher, this is expected, right? Because it's the differential between your inlet and outlet. And so understanding if you're trending values, knowing whether or not the increase is due to a change in flow is very important. So some of the reasons for excessive too high transmembrane pressure is, again, too much blood flow, too high hemoglobin because you increase the viscosity of the medium, high triglyceride, or probably the most common, other than too much flow in clinical practice, is deposits on the membrane. So the membrane, I think I have some pictures later of what the inside of these membranes look like, but they're very densely packed with fibers, very, very small fibers where gas flows through. And this is very prime location for deposition of cellular material, cytokines, inflammatory markers, thrombus, fibrin. You can see here, these are membranes that were washed with crystalloid after they were run, and you can see all the thrombus. Put it under an electron microscope and you can actually see all the platelets that lay over the fibers and the other cellular material. This is actually very common during ECMO and is really expected to happen, but we can temporize a little bit. And it's important to know the situation where it may be detrimental, which we'll talk a little bit more. So the relationship between the pump speed and the flow is something that's very important. It's often assumed that these are linear relationship, which if we recall from the pressure flow relationship, this is in theory true, but there are reasons when it cannot be true, and it's important to understand those. So contemporary ECMO use centrifugal pumps. I'm not sure if there's really any pumps that are commercialized today that still use rollers outside of the cardiopulmonary bypass machines. But again, the relationship between the speed and flow is important. And these pumps are sensitive on afterload. And so if you have very high afterload, it impairs the function of the pump. Pump speed is one of few things that you can change on an ECMO circuit. You cannot change the pressures, you cannot change the flow, you only change the speed. The flow is the computed output of how much speed you have set based on all the other characteristics. And so the speed, you'll see on your console, you'll see the flow and all the pressures that are generated. You can have situations where there's a disconnect between the speed and the flow. One of the most common reasons for this is if you have some thrombus in your pump. This can create a phenomenon called pump drag, where you keep increasing the speed, but the flow doesn't change as much. And so it's often called a pump drag, and there's really not a way of diagnosing this during ECMO. You only know after you come off and you interrogated the circuit. The plasma-free hemoglobin is also a way to understand issues with the pump and the membrane. This is a very nice case series where you can see very high plasma hemoglobin levels, and then when the membrane or pump was the entire console rather was replaced, the free hemoglobin went back to normal. So again, if we have a high amount of blood flow that is passing through an area of high resistance, we're hemolyzing blood and generating free hemoglobin. There's ways to do safety checks on these devices. The 4 things that come to mind that are usually most critical, you can think of it in this POWA acronym, is the power, the oxygen, the water, and the alarms. And so always you have a dedicated outlet for providing this, and so in the ICU we wouldn't stick it into a strip like this. We would have it into a circuit. If you have an outlet that provides power even when the central power goes out, that's important. Batteries, if your system is equipped with it, are fully charged for transport. Oxygen has a dedicated wall source, and you have backup tanks. I don't see that we have tanks here, but when we look at these later, you can see there's spots on the back where you can affix tanks to them, so you can hook up your gas line when you do transport. Also with oxygen, having backup flow meters and seeing that there's good color change with your cannulas and your membranes are functioning. Water, these systems are equipped with thermal regulators. It's the big boxes you see on the bottom here. They're water baths that can heat, and those flow through other fibers in the membrane to provide thermal regulation. And then also the alarms that you can set on the system to alert you when there's some deviation from what's expected. Some of the other things, some of these things may seem obvious, but they're very good to have protocolized at your institutions if you provide the support, is that you should position the circuit appropriately in the room, understand where people come in for things. If you have x-ray coming in, which side of the bed so that the circuit's on the good side. I know we're not talking about cannulation here, but also the twisting and coiling of the tubing is important too. So have a good relationship between your bedside staff and the cannulators, so that when you go on ECMO and you connect the tubing, it's very challenging to untwist things, and so having it positioned appropriately before you go on the pump is something that seems simple, but usually is an issue. Making sure that things are accessible, that you can, if you don't have like a specialist, like an ECMO specialist in the room, that you have the ability to see the console from the outside. The equipment should obviously be clean and organized. These things have brakes on them, so they can't be dragged, so activate the brakes. And then positioning things so that you reduce the risk of bumping or manipulation or stepping on gas lines or cannulas or kicking power outlets. Again, these are things that seem simple, but they can have bad consequence. So we'll talk a little bit about different aspects of monitoring in ECMO. So circuit monitoring, the most important is early recognition, because you can really prevent catastrophes. Frequent inspection, developing protocols within your institution that has a systematic way of inspecting various components of the device to document how things are functioning. And then follow the circuit. We do this, and I'll show an example of this, of what we do at our center. But following from the insertion site all the way back to the return insertion site, inspecting everything along the way. And I'll show some examples of that. So the insertion sites require monitoring. Obviously, these are large bore cannulas. You should assess for and prevent breakdown or injury to the site, use dressings as appropriate, prevent infection. These things bleed a lot, especially arterial sites, depending on the sizes of cannulas and if you have a cut down or no cut down. And then also ensuring stability of the insertion site. Things to look out for are assessing for signs and symptoms of infection. Again, having appropriate site guidelines for care of these insertion sites. And then protecting the peri-wound skin is very, very important. And then always have the ability to visualize the site. This is something that can be overlooked, but being able to have an inspection to see if things are going wrong is important. Manipulation, and again, being positioned appropriately is important there. There's different securement techniques. You can use sutures, adhesive devices. One thing that is a very interesting strategy is to use a marker to assess the positioning. So if you put a marker where the metal part of the cannula ends, you can monitor the daily progression if there's migration of the cannula. That's a very easy way that's non-invasive to be able to see if you have an issue. Assessing the security of your sutures, if you need to add more sutures or not. And then again, positioning and movement. If you're, depending on the type of support you're doing, if your patient is active, walking around, assessing those things perhaps more frequently. You can also monitor cannula positioning on chest x-ray. So here's a nice example of migration. This is quite dramatic migration, but you can see the trend here. If you're doing chest films daily, you can see this happening. There's some useful measurements that you can do to assess for migration. So we can see here a veno-venous configuration where we have a drainage in the right groin and a return cannula in the right neck. You can use the tips of the cannulas and also the carina as a reference, and then perform these measurements to see if there's day-to-day variability. The drainage tip to the carina, the return tip to the carina, and then the tip of each cannula to each other. One thing to be aware of is understanding what types of cannulas you're using, because certain cannulas will not have radio-opaque material all the way to the end of the cannula. So just because the radio-opaque portion of the cannula is visible, that may not necessarily mean that that's the actual tip of the cannula. So just be aware of the materials that you're using. We also monitor the tubing, the integrity of the tubing, making sure that there's no kinks in the tubing, there's no tension in the tubing. Monitoring all of the connections. You can make ECMO as complicated as you want, and then also securement of the tubing to make sure that there's no accident disruption to the integrity of it. Something that we do is frequent inspection of the tubing. So here we can look for thrombus, fibrin cracks, air. One very important thing that we didn't talk about is tubing that you see in most parts that's transparent is flexible, it can be clamped. There's other portions of the circuit that are rigid plastic or metal that should never be clamped unless if it's an emergency. And so you could have cracks if the incorrect portion was clamped. And then also assessing for air entrapment. Other things to assess with tubing is flow or stagnant areas. The most relevant is when you Y-site. Maybe you have two drainage cannulas and you Y-site the cannulas into the pump. This produces a turbulent flow, and you can have lots of thrombus grow there. The color differential is a very simple, cheap way to see if your membrane is working. Right? If you have nice, dark venous blood, and then you have nice, fresh red blood coming out. And then very rarely you could have a tubing rupture. But this is a nice example of, you can see here, some fibrin growing off that outlet connector. This is coming off of the membrane. And maybe you can see also the reason the blood is different color, it's a flashlight. So don't be afraid to use a flashlight, get close to the circuit, look at this from start to finish. The pump requires monitoring, the appearance of it, the connections, the temperature. These are mechanical devices, and so they can produce heat when you're not functioning, or excessive heat if they're not functioning appropriately. Sounds is something also to be aware of. If you have some thrombus developing in the pump, it can generate some sounds like it's chewing, similar to LVADs, it generates sounds from the thrombus. The membrane can be monitored too, investigation of the faceplate to see if there's some thrombus growing. The connections on the membrane, there's, depending on the device, there's different access points that you can have. The function of it, obviously the most important function is the clinical response. So you can have thrombus on the membrane, you can have higher pressures, but if you have a satisfactory gas exchange, you have a satisfactory arterial saturation, there may not be a reason to exchange things. And then also the exhalation port on the device should be unobstructed at all times. Another thing we can monitor is this goes with the function of the membrane. Many cardiopulmonary bypass use polypropylene fibers, and some echo pumps still do today. Some of the newer fibers are the polymethylpentene fiber. The difference here is these fibers, they have pores. So this is where the gas exchange occurs on polypropylene fibers. They have a hydrophobic coating that prevents the blood from leaking into the fiber, and so the gas exchange happens across the pores. In the newer fibers, the gas exchange occurs across a diffusion gradient because the fibers don't have pores. It's important to know which fibers you use because you can have deposition of drugs, lipid material, other type of material into these pores. And so knowing if that's a mechanism of a failing membrane when you provide support is important. Some of the other things for monitoring the membrane is if there's a hematologic abnormality or if you have an obstructed blood flow and what the status is of your gas exchange. This is a nice flow sheet of identifying what may be the issue contributing to membrane failure. So again, at the top we have the three major causes: the hematologic issue, coagulopathy and hemolysis, a pressure issue that's usually from obstruction, or a gas exchange issue that affects the oxygenation or decarboxylation. The temperature box is also something that requires monitoring. You can set the setting on it, so sometimes people may forget that the temperature is set high, and they say that a patient has a fever, but it may just be that the thermoregulator was set too high. These have a water reservoir, so it should not be accessed too much because of infection issue. And then also making sure that all the cables are appropriate. The temperature boxes, they all have a different cleaning protocol. Usually we do this between ECMO runs, but there may be reasons to assess it during. So we'll go into some, maybe I'll pause for a moment here and see if there's some question, but we'll go into some issues that can create an emergency situation and what the intervention are for those emergencies. So are there any question about the basics? So circuit emergency is usually these four things: air, bleeding, clot, decannulation, ABCD. Air is air entrainment. So the ELSO estimates that about half of ECMO runs have some degree of air entrainment at some point during the run. Most of this is non-consequential. Some reasons for this are medication, accessing the venous ports. Perhaps a connector was left open. If you clamp the wrong place and you have a crack, you can have air entrainment that way, or if you obstruct the exhalation port on the membrane. It may be surprising to hear that 50% of runs have an air entrainment. This is because there's two different types of air that can happen. You can have a micro air, where these are very small air. Most of the time, these are can just be aspirated out from the membrane access. Some issues where this may come from is the connection when initially going on pump was not appropriately de-aired, or you could have some medication introducing bubbles. Macro air is much more consequential. This can make the device fail, and so you could lose support. This could be because of cannula dislodgement, right? If you have a migrated cannula, let's say a drainage cannula, and you expose one of the holes, you can have massive air intake. This is an emergency. Macro air is emergency. You clamp the circuit, you come off ECMO, you find where the issue was, and you replace the system. B was bleeding. There's many circuit-related issues that could contribute to this, and also the patient issues. Usually just correcting the coagulopathy is the approach. Clots can happen where there's low or stagnant flow or turbulent flow. So use flashlights to monitor your system. Understand that there are normal clots and there are also bad clots, and when you should and shouldn't act on things. Here's some example of fibrin. We looked at this picture earlier, but here you can see some other straining here, some fibrin straining there. usually they latch onto those connections. Also on the membrane, you can see lots of clot in there on the membrane, lots of clot there, some fibrin. You can see this very nice clot in this tubing after being removed and washed with crystalloid. It just hangs around. This is what we developed at our center. So this is specifically for the CardioHelp system, but if you develop a similar protocol for monitoring, it can be very helpful to find these things. And so we developed a map of what the circuit looks like from start to finish and labeled each with a number. And so routinely, every couple hours during the day, we take a flashlight from insertion site through the entire circuit back to the return insertion site and document where there is issues, if there's cracks, if there's fibrin, if there's thrombus, so you can monitor how it's changing over time. Decannulation is the last emergency. This is rare, but it's almost always catastrophic. This is when you have accidental removal of the cannula. And so you imagine if you're on 5 liters of ECMO, within a minute and a half, your entire circulatory volume is on the floor. This can be avoided in most situations, again, by routinely monitoring cannula positioning. Okay. So is the time okay? Yeah. So with the last section, before we have some cases, I had to talk about some hypoxemia on VV ECMO. And so there's some reasons you might have a hypoxemia. You could have a failing membrane, the device isn't working. There could be a shunt, or you could be having a phenomenon called recirculation. And so we'll talk about these things. So the shunt on VV ECMO is the amount of blue blood that the ECMO circuit is not seeing. And so you can see here the shunt fraction is the amount of flow to the total cardiac output. So if your total cardiac output is 10 liters per minute and your ECMO flow is only 2 liters per minute, you have a very low shunt fraction. And so if you have a high cardiac output or low ECMO flow, this can produce a hypoxemia, no matter how well your device is functioning. So there's ways to address the shunt. If it's because, so you can increase the ECMO flow. Again, you increase the amount of blue blood that ECMO sees. Sometimes, again, remember the relationship between flow and pressure. You can't increase the flow too much. You may be limited by pressure. You may need a different cannula size to provide more flow, or you might need another cannula. You could also decrease the cardiac output. This is usually not a preferred option. It can be very tricky, and usually you just treat the reasons. If you have a hyperdynamic output, you treat those reasons like a fever, sepsis, something else.
So by beta blockers?
Beta blockers, sure, yeah. But be very careful if you have like a tenuous heart function.
So the beta blocker is something that comes up all the time.
Yeah.
At the end of the day, what we want to remember is the goal is to maximize oxygen delivery. So if you improve your oxygenation, but your overall oxygen delivery is decreased because your cardiac output is now too low, you may not actually achieve your goal. So it's always a balance between someone who's studying in the mid-70s with a very high cardiac output, their oxygen delivery may be higher than if you have a saturation of 99% and a low cardiac output. So it's benefits and risk. And there's a paper that I can show you after where they actually calculated the oxygen delivery. It was lower when patients were on beta blockers, rather than a higher cardiac output and an oxygenation that was very high. So it really depends on where you are, but at the end of the day, you need to remember that what matters is what your cells are seeing, not just so much your oxygenation.
The recirculation can also cause an issue with or produce hypoxemia. This is a phenomenon where your fresh red blood is going back into the ECMO circuit. So usually the most common reason for this is the cannulas are too close to each other. So if you're in the neck and the groin, and they're very close to each other, you reinfuse the fresh blood to the ECMO circuit. If you have a dual lumen cannula, so we didn't talk about this at the beginning, but you can provide VV ECMO support with one cannula that has 2 lumens in it, one for the inlet, one for the outlet. If that cannula is malpositioned, if it's rotated, and it's not facing the tricuspid valve, then you could have recirculation. If you're trying to flow too much, you have too high of a negative pressure, you're more likely to pull that fresh red blood.
How would you know you have recirculation?
Good question. So there's a way to calculate a recirculation fraction. This is usually not done during practice too much. Many of these systems, you can measure central venous oxygenation. So it's the saturation on the inlet pressure, on the inlet line, which is, you could equivalent to a SCVO2, because it's from the great vein. And so looking at the trend of the SCVO2 over time can give you a sense of recirculation. A more obvious way, if it's very dramatic, is the color change in the cannulas. So if you have the same, there's no color change, you have the same, what looks to be the same colored blood coming in and out, it's probably recirculation.
Sometimes you just see flashes of oxygenated blood mixed with venous blood in your cannula. And then, as you mentioned, you can either have continuous monitoring of your pre-oxygenated saturation, or you can do a blood gas just before the membrane. And if that oxygenation is really high, that probably indicates that you have some recirculation. And the last thing is that clinically, if you increase the flows and your patient desaturates even more, that means that you're actually stealing the blood from the pulmonary circulation, so that's another sign of recirculation.
This recirculation happens only with cannula dual.
Admittedly, one of the selling points of the dual lumen cannula is that you have less recirculation. In practice, it's very positional, and if your return port is not exactly where it should be, you'll have a significant amount of recirculation. But they will tell you that they have less. In real life, it's not true.
Yeah. So here's some configuration. So we saw earlier, usual configuration of VV ECMO is a groin drainage and a neck return. And so you can have a recirculation in this situation, but again, it can happen with any configuration. You can provide VV ECMO through the groins, so having both cannulas in the groin, and you can have a recirculation with this. There's a debate of how much this can actually happen. There's usually a lot of hesitancy of this configuration because the cannulas overlap. But if you use a drainage cannula that has multiple ports, most of the drainage occurs proximal to the pump, and so it may actually drain lower than the perfusion cannula.
Some centers do exclusively that.
Yeah.
So, and there's a significant overlap between the cannula, and you just need to have enough distance between the return port and the proximal hole of the drainage one to not have recirculation. And irrespective of the configuration, the proximity is not as important as the direction of the flow and that distance between the return tip and the proximal hole from the drainage.
And if you try to flow more and more and more, you increase more pressure, and so you drain from more distal holes, which could increase the recirculation of that configuration. These are some of the single cannula configuration. This one has a drainage, two drainage, one in the superior and one in the inferior vena cava, and then the return port is positioned at the tricuspid valve. So again, if this cannula is rotated, you produce a lot of recirculation that way. Maybe the Protec Duo is the one where it should exclusively be no recirculation, because you drain in the right heart and you return in the pulmonary artery. And so this, if you have competent valves, should not actually produce a recirculation. Should we have the break and then do the cases?
Yeah, I think so.
Yeah, okay. Yeah, we can have a break.
You guys ready to break?
Yeah.
Anyone need to
Ready
wake
or
up?
not, ready or not.